Hi, this is Brian Kim. I'm going to share with you this case of a patient who was sent to me by a retinal specialist. The patient was left aphakic and was sent to me for a secondary IOL placement. And so I'm going to show you my modifications to the Yamane technique and my stepwise approach to get a consistent and reliable outcome. You want to mark the conjunctiva, but not just that, you want to be able to fixate the conjunctiva in the neutral position for the scleral needle placement in order to get a reliable needle placement. If you don't have the haptics in the sclera consistently, you can have decentered or tilted lenses. You also want to do the trailing haptic first technique, which allows you to pull the leading haptic through a contralateral incision and allows the trailing haptic to be fixated much more easily. And this has been my experience and the experience when I teach this in the wet labs. You also want to capture the trailing haptic through the main incision in a U-shaped configuration so you can grab it and fixate it very easily. You have to bend the needles in such a way that the bevel faces the approach of the haptic, so you can dock the haptic on the bevel of the needle, flatten the haptic to straighten it out, and then you can advance the haptic very nicely into the needle. With all these adaptations and specific steps that I do, I feel like I get a much more predictable and reliable outcome with the Yamane technique. You need a dry conjunctiva to be able to mark without it smudging. So I'm drying with the cotton tip, and then I'm using an ink pen to mark the limbus on the left side here. And this is the left eye of a patient, and I'm sitting in the supratemporal position. I'm using an axis ring to find 180 degrees apart from that initial mark. And I like to use the tip of a cannula, which is a nice and round surface to be able to create that ink mark. I use a caliper to mark 2.5 millimeters posterior to the limbus on each side. You can see with the caliper, I'm able to maintain a completely radial mark, and that's very important, have radial marks. And now I'm using the caliper to mark 2 millimeters adjacent to this posterior mark on each side. On the left side, it's going to be a backward 7 orientation, and on the right side, it's a backward L configuration. I'm making my contralateral limbal incision with this metal blade. You're going to see that that metal blade is not what I normally use. I use a diamond blade, but in this case I have this metal blade, and it does interfere with my ability to place my microforceps. I should have widened the incision, and you'll see that in the video. I'm making another incision for my anterior chamber maintainer. I'm injecting some dispersive viscoelastic to fill the anterior chamber. I'm making 2 additional paracentesis incisions. The left side I'm using so that I can hold the eye to make my triplanar corneal incision, make a vertical groove, go into the groove, tunnel into the cornea, and then dive down. I did cut through one of the sutures there, but that's okay. I put my anterior chamber maintainer, and then I'm putting in the CT Lucia 602 lens. I have in my left hand my micrograsper. I have my right hand. I'm holding the injector. My technician is advancing the lens. As the lens comes out, I ask her to stop so I can grasp the tip of the haptic. You can see there's some distortion to the cornea, and that's because my forceps is getting caught in the incision. I could have gone back and just widened the incision, but instead I just go ahead and find that tip of the haptic, and then I pull it out through the limbal incision. Once it's out, you want to release on the left side, and then I'm able to dial the optic in myself, rotate the barrel to make sure that the optic comes out in a planar configuration. Normally I sweep the trailing haptic to the right, but in this case it went out in the correct orientation. I use the McPherson's now to capture the trailing haptic within the incision in a U-shaped configuration, inject some viscoelastic to coat the corneal endothelium and to push the optic back. I'm going to work on the right side, and I already have my needle bent 9 millimeters from the tip at 70 degrees. I'm going to use forceps to grab the limbus tissue here to put the conjunctiva in the neutral position. I'm going to place the needle through the sclera, go 2 millimeters, and then dive down. You can see the conjunctiva is in a neutral position the entire time. The bevel is facing towards me, towards the haptic here. And then I'm using microforceps to grasp the apex of the U. And then I'm going to dock the haptic on the bevel of the needle, which faces the haptic. I'm docking it here. I'm trying to find the bevel. Now I dock it, straighten it out, flatten it out. I'm able to advance the haptic. And so let me show that to you again in slow motion. I'm grabbing the apex of the U on the haptic, which is the perfect place to grasp the haptic through the main incision. You see the haptic is curved, but the needle is straight, but the bevel is facing the haptic. I'm going to take advantage of the bevel of the needle. I'm going to dock the haptic on the bevel of the needle there, flatten it out, straighten it out. Because the haptic is straightened, I'm able to advance it very nicely and easily into the needle. I'm using a hemostat to disengage the syringe from the needle. It's very important that you don't have the syringe too tight on the needle, because when you're trying to disengage the syringe from the needle with the hemostat, it can be very difficult. So again, you want it snug, but not so tight that it's difficult to disengage the syringe from the needle. So we're working on the left side now. You can see I'm holding the eye on the top of the screen on the conjunctiva and sclera. I'm tunneling with the needle 2 millimeters and then diving down. I'm able to keep the eye in the neutral position with this technique. Again, it's very important to fixate the conjunctiva in the neutral position so that you have accurate and correct scleral needle placement. First, I'm trying to internalize the needle through that incision, but it's actually better to go through the main incision with both haptic maneuvers. And I'm just going to try and find a little bit of a closer to the end of the haptic here. It's still a little bit too far. So I'm going to go back again and try to grasp it a little bit more proximal. And now you can see I'm able to dock the bevel of the needle, straighten it out, and then advance it. I was able to do this through a small pupil on both sides. And again, the reason I can do that is because of the docking of the haptic on the bevel of the needle principle. So I'm going to show it again in slow motion here. You can see I'm holding the haptic, flattening it out on the bevel of the needle, straightening the haptic, and then I'm able to advance the haptic onto the needle. And so this small pupil case, you don't have to use retractors or a ring necessarily. You can if it helps you and makes you feel more comfortable. But the principle of docking the haptic on the bevel of the needle, it's vital to have a very smooth and predictable way to thread the haptic into the needle. So I'm pulling the left needle out. You want to pull the needle out in the direction where it came from. So as I'm pulling it out, I'm making sure not too much of the haptic is externalized. You don't want to cause any traction on the haptic on the right side. And so then you grasp it and then you cauterize the tip. And now I'm going to pull out the needle on the right side. Again, you're pulling it out in the direction of the scleral tract. So you're pulling the needle out in the direction of the scleral tract. As you're pulling it out, you want to make sure that the haptic doesn't come out too much. Again, by pulling out too much haptic, you're actually causing stress on the haptic, especially on the other side. I'm grasping the haptic with forceps, and then I'm going to cauterize the tip and create a small bulb on the end. I have small bulbs on both sides now, and then I'm going to push each of the bulbs flush to the sclera, internalizing the haptic on each side. You want to make sure that the bulb is firmly embedded into the sclera on each side. As you can see, I did this Yamane style technique with my modifications without a lot of surgical gymnastics. I'm going to do my vitrector assisted peripheral iridectomy. Through a nasal incision, I'm going temporally, and you can see it uses high vacuum with limited aspiration with foot pedal control at a very low cut rate. And so by doing it this way, you can get a really nice small and round peripheral iridectomy. I'm going to go ahead and place another suture with a 10-0 nylon, and I sped this up just for time's sake. Since my incision intersected with the other surgeon's incision, I decided to go ahead and suture the incision. I removed the anterior chamber maintainer and hydrate my incisions. So again, this is a patient who had a dislocated IOL that fell into the vitreous space. The retinal specialist took the lens out and then left the patient aphakic and referred the patient to me for secondary IOL fixation. I performed my modifications of the Yamane technique and my stepwise approach. I did the Trailing-Haptic first technique, conjunctival marks, fixating the conjunctiva in a neutral position for scleral needle placement, turning the needles in a controlled way, an easier way by docking the haptic on the bevel of the needle. You can straighten out the haptic and then thread it through the needle much more easily by taking advantage of the bevel. Creating a U-shaped configuration through the trailing haptic through the incision to be able to fixate the trailing haptic much easier onto the bevel of the needle. With these modifications and steps, this makes this surgery a much more predictable and a routine surgery. And you can see in this case, even in a small pupil situation, by taking advantage of these principles, you can do a fairly straightforward, modified Yamane technique. So I hope this was helpful to you, and I thank you for your attention.